Well, good afternoon, ladies and gentlemen. It's an absolute pleasure to welcome you to our lunchtime session of integrated management for transplant-eligible myeloma patients. And it's my pleasure to present this to you this afternoon with my colleague and dear friend, Faith Davies.
The following audio is part of a certified educational activity titled Integrated Myeloma Management for Transplant-Eligible Patients, the conjunction of novel therapeutic platforms, innovative agents, and HCT. Access the entire activity and complete the post-test at www.peerview.com/JDR. Downloadable slides and practice aids are also available.
So we're now ready to get started. And what I wanted to do was to sort of talk to you in broad brush about therapy for stem cell transplant eligible patients as a segue to then having a wonderful piece from Faith to follow about what we do for relapsed refractory disease. Now, most importantly, by way of introduction, I want to really start by giving you some biological sort of background. I think first and foremost, it's important to recognize that myeloma is highly heterogeneous. And obviously, this recognition of clonal heterogeneity has been really essential in our ability to individualize treatment, and with the advent of novel therapies, really the opportunity to tailor therapy has become a reality. And this is, of course, premised on risk stratification. Now, what's very important to also understand is that this heterogeneity doesn't exist just between patients, but can exist within a patient. And this real entity of clonal heterogeneity and its clonal tiding that follows is something we'll come to in a minute. But I think in that context, what has been so fortunate in the last 15 years or so has been our ability to target myeloma, not only itself, but in the context of the microenvironment, with a multimodality approach, pharmaceutically, immunologically, and otherwise. And this diagram from my colleague Giada Bianchi, I think, is a lovely summary of it. It's busy, and in the interest of time, I won't dwell on it, but suffice to say, as you can see, each of these represents a platform through which we target the disease, be it proteasome inhibition, immune modulation, HDAC inhibition, immunological manipulation, targeting the bone, cortical bone environment, angiogenesis, and of course, critically, the immune system, which we'll talk about in more detail. Now, what has this translated into? Well, the good news is that there's been a consistent improvement in survival in myeloma. And this really has been, in terms of our disease, quite unprecedented, as you can see. But I think before we become too effervescent, it's important to recognize that we still have an unacceptably large number of early deaths with high-risk disease as that evolves early in the patient's course. And unfortunately, we still really don't have a plateau. Although I would propose to you, and you'll see some lovely data from Faith in a moment, that with the advent of monoclonal antibody therapy, this may be changing. Now, by way of background, it's important to also share with you that multiple myeloma is truly a marathon in terms of the therapeutic paradigm. It is certainly not a sprint. And therefore, as we think about where we manage the disease, be it from symptomatic disease through plateau and remission and maintenance to the relapsed and refractory setting, this is a long haul, and we have to therefore bear in mind not only how effective our therapies are, but the importance of toxicities, both acute and long-term, as well as quality of life. And I especially want to acknowledge also the very exciting work that's being done in smoldering disease with the construct of a stitch in time saving 9. In the interest of time, we won't go into that space in more detail, but suffice to say, a very promising area. Now, what about the most recent changes in myeloma care? Well, a couple of things to share. Obviously, in the last 15 years, we've seen an unprecedented pace of new drug approvals in myeloma, 22, in fact, in the last 14 years, in terms of actual approvals of indications, not just drugs alone. And this diagram summarizes some of the key advances, from proteasome inhibition to immunomodulation to the arrival of the monoclonal antibodies. And what I show over to the right here is a lot of exciting new stuff to come. And again, Faith will touch on this in more detail. So we have multiple options to treat both newly diagnosed and relapsed refractory disease, and we have to think about how we best sequence treatments to improve outcomes for our patients. As I mentioned before, this clonal heterogeneity is something we really have to understand and appreciate as we treat our patients. And it's very true that clonal evolution can result not only in disease progression, but also can be manifest from the effects of therapy. And this is an important thing to bear in mind. And this summary diagram really captures it from a recent review from Dr. Manier and colleagues, where you see this co-occurrence of genomic events and clonal evolution during progression in myeloma. And my final introductory slides are to give you, I think, some words of sobering caution. This is from my colleague Nikhil Munshi, and it's from one of our prospective trials. And what you can see is whole genome sequencing at diagnosis in this particular patient. And Nikhil's work very beautifully shows here over 5,000 mutations in this patient's disease. This patient subsequently goes on to induction remission therapy, transplantation and maintenance, and then unfortunately relapses. And that relapse, what is particularly sobering is this, that the whole genome sequencing reveals no less than 12,000 mutations at that time. So we clearly have an enormous task ahead of us to beat this. So what about our key targets going forward? Well, they're summarized here. As I've mentioned, genomic abnormalities are essential. We must target and overcome them, and you'll hear both from Faith and I in that regard. The critical role of combination therapy and continuous treatment underpins this. I would propose to you that we also need to minimize genotoxic injury, not only from the point of view of toxicity, but also from the possibility that we might magnify what I just showed you. And in that context, we need to think about the evolving position and timing of transplant. And then in terms of very exciting new directions, there are multiple areas under study. Two that particularly capture my attention and I think are areas of great excitement are continued work in the world of targeting protein degradation and, very importantly, the whole new frontier of targeting immune suppression. So in terms of this afternoon's agenda, as I mentioned, we're going to look at transplant, and I'm going to dwell on that for the moment, looking at both induction regimens, the role of transplant, and of course maintenance, as well as the role of MRD. And then Faith is going to play a critical role in bringing this together, in discussing with you what happens at relapse, which unfortunately is uniform, or almost uniform, for all of our patients. Well, now we'll get started with the main frame of the induction remission strategy and where transplant belongs. So my premise this morning is or this afternoon I should say, is to bring to you what are the current standards for induction and maintenance prior to transplant in transplant-eligible patients. And I just proposed to you that there is a clear model for treating transplant-eligible patients currently, and that involves basically diagnosis and risk stratification, assessment of whether or not this is an appropriate modality, an induction remission strategy, intensification and consolidation, followed then by maintenance until progression. Now, the principles of initial treatment are summarized here. We do strongly believe that triplets are preferred, and I'll show you evidence to support that. Typically, this is a proteasome inhibitor, an IMiD, and a steroid. There is a role for cyclophosphamide, bortezomib, and dexamethasone, but we also recognize, and I'm coming to it in a minute to reinforce this point, that next-generation proteasome inhibitors such as carfilzomib may be particularly important in this setting, particularly if there's a risk of neuropathy. Now, what do we do about doublets? These are relatively rarely used. For example, we might use bortezomib and dexamethasone in a patient with renal failure initially, and then we might add an IMiD or add a cyclophosphamide, for example, going forward. But doublets, basically to date anyway, based upon randomized data, seem to be inferior in this setting. So again, the choices should be tailored to the patient accordingly. And very importantly, in maintenance, lenalidomide, I think, is established as a backbone, and we'll show you evidence to support that. And then at the same time, in higher risk patients, there may be a role for adding a proteasome inhibitor to that platform, be it bortezomib or otherwise, in high risk patients. Now, what is the best evidence for the role of transplant and triplet induction therapy in transplantation-eligible patients? Well, I want to share data from my colleague, Michel et al., and the IFM 2009 study, which was published in the New England Journal last year. And this study looked at RVD induction, followed by collection, followed by transplant, consolidation, and then maintenance. And then the French trial was limited to 12 months. The control arm consisted of keeping transplant in reserve. And as you can see, both arms performed well, but in fact, there was a clear progression-free survival advantage supporting transplant so far. What was striking, however, was the absence of a survival benefit. But that being said, the results from this trial remain exceptional and some of the best in the randomized trial setting. So they clearly support the use of an induction remission strategy with a triplet, the use of transplantation, and consolidation and maintenance to follow. One of the challenges, of course, in this particular study was the fact that lenalidomide was curtailed at 12 months. However, if you look in detail at this, you can see high qualities of response in both groups. And what's particularly interesting is that MRD negativity is achieved with RVD alone, without transplant, in a significant proportion of patients. But having said that, it's statistically significantly higher for those who receive intensification with transplant. Now, what about the triplet regimens in themselves? Well, comparisons of triplets versus doublets have been best addressed by a variety of studies, but probably the foremost is that of Brian Drury and the SWOG group, in which they compared a triplet to the doublet in patients without immediate intent for transplant. And what you saw here was not only a striking PFS benefit to the triplet, but also a survival benefit becoming apparent very quickly. So in summary, triplets versus doublets, there is a high level of evidence to clearly support their use in the initial therapy setting. Now, what about maintenance? Well, this has been an area of considerable debate and research for the last 10 years, but I think the very good news now is that we have a very clear picture. And this is largely based on the seminal work of my colleague Phil McCarthy and others, in which we've been able to do a meta-analysis of lenalidomide maintenance and clearly demonstrate that there is in fact a survival benefit to this approach, and it is until progression. So critically, this approach, therefore, we think becomes a standard of care in those patients in whom this can be reasonably pursued. And what's also very important to note is this also appears to matter after transplantation in the French data that I showed you earlier, as well as forward trials. Now, this has been further reinforced by some lovely work from the British group led by Graham Jackson, in which actually Graham presented this data, I should say, at an oral session in ASH December last year, in which he showed strikingly similar results, really emphasizing this point, that lenalidomide maintenance until progression post-transplant was highly effective. And what was important was that it was effective irrespective of cytogenetic risk. Having said that, there is now a wealth of data to support the use of proteasome inhibition in combination with lenalidomide to build upon that, and we'll come to that in a bit more detail. Now, one area of considerable debate has also been the role of single versus double transplant. And I think in that regard, the question is it an option? Well, certainly there appears to be an evolving role for both approaches in the transplant-eligible setting. But what's very clear is that in the era of novel agents, tandem transplantation has typically been restricted to patients with higher risk or in whom there has been a failure to achieve high quality of response to additional induction remission therapy. So I think this is a very important concept. Now, data from our European colleagues would therefore support that double transplant can be considered an important option for higher risk patients and those achieving lower quality response. And the data for this comes from studies such as the MN study. This was recently updated by Michele Carvo at ASH in December of last year. And this is a complex algorithm, but just to share with you that it involved tandem or single transplantation, VMP as a control arm, which is of course a caveat here, and then the classical triplet of IMiD, proteasome inhibitor, and steroid was actually reserved until consolidation. So an important difference here is that the triplet induction consisted of VCD followed either by VMP versus transplant, and then there was a somewhat different approach, therefore, to initial induction remission therapy. That being said, however, there was clinical benefit for the second transplant, particularly in the context of higher risk disease. So this is an important point. This is the response summary, which generally suggests that these results may support the use of upfront double transplant in patients with high risk disease. However, is this validated in other studies? Well, certainly in the context of the US study, we have a very important CTN effort, the Stamina trial, led by Amrita Krishnan, Ed Stadtmauer and colleagues, as well as Marcello Pasquini and others, in which this is the largest comparison to date of therapeutic approaches after first transplant in myeloma in the US, with classic induction remission therapy being typically a proteasome inhibitor, an IMiD, and a steroid, recognizing that randomized data, in fact, from Europe suggests this approach may in fact be superior than, for example, CyBorD. This is an algorithm of the Stamina trial, its design. It enrolled almost 760 patients, and Ed presented this as a late-breaking abstract at ASH in 2016. What's important to share with you here is that there is no difference in PFS or OS at 38 months of follow-up for any of the arms tested. And in particular for tandem transplant, what was obvious was that up to a third of patients were unable to go on to proceed with this modality. So I think there are clear caveats to the use of tandem transplantation in this setting, and particularly now that we have next generation agents and antibodies that are on their way and already under study. So basically, in the next few minutes, I wanted to finish by focusing on these newly developed induction remission strategies and share with you some of the very exciting data from them. The first I want to share with you is that of the carfilzomib, lenalidomide, and dexamethasone platform developed by Andres Jakubowiak, Todd Zimmerman, and colleagues leading from the University of Chicago. And what Todd and Andre presented at ASH in 2016 were the results of their KRd induction remission strategy with or without transplant, followed by consolidation and maintenance. And a number of centers participated in this trial, including our own, and we were very struck that there is clearly high rates of deep response with the use of KRd, with higher rates of stringent complete response compared to those where transplant is not used. So clearly, again, this response signal being apparent. What was also interesting was MRD negative disease was higher, basically, when you used KRd with transplant than without, but nonetheless, the rates for both cohorts of patients remained very high, and deep responses with KRd plus transplant did appear to be associated with higher rates of PFS and perhaps a hint at overall survival benefit. But again, this was not a strictly randomized comparison, this was rather sequential, so I think one has to be a little careful. Now, perhaps a more real-world experience was presented by our French colleagues, led by Marianne Roussel. What Marianne and her team did was to look at KRd in newly diagnosed myeloma in a multi-center group setting, specifically the phase 2 group of the IFM. And what she showed very nicely was a very similar high quality of response with this intensive regimen, which was more rapid, in fact, than typically seen with RVD, although overall very similar. And what was very important was this very high rate of MRD negativity, but this again was very similar to what was seen with RVD. What was the caution here was that there were, in fact, a number of vascular toxicities encountered in the IFM French study that were noteworthy. And 30 of 45 patients experienced an SAE, including cardiac and vascular issues, in about 20% of the patients. So this was very important. This also resonates with other studies in which similar toxicity profiles have been seen. So recognizing that in general, KRd is well tolerated and extremely active, some caution for those patients who may be at risk of cardiovascular complication is real. Now, what about other induction remission strategies that build upon RVD, KRd, and may have certain advantages? One of the most interesting ones, in my view, is the combination of Ixazomib, lenalidomide, and dexamethasone, and I'm profiling here work of my friend and colleague Philippe Moreau from the IFM, in which the IRD regimen has been explored as part of an induction remission strategy for transplant, building on excellent work led by Shaji Kumar, showing this to be a very active and effective regimen, also benefiting, of course, from the convenience of being all oral. And what Philippe shows is that actually there are excellent results seen, but actually, in fact, in terms of the quality of responses, as compared to what we see with either RVD or KRd, certainly the rates of VGPR are not that comparable. And so in the context of late consolidation, yes, we may be where we need to be, but certainly early in the game, the quality of response, certainly prior to transplant, does not appear to be as high. And so this was an interesting caveat to this trial. However, at ASH last year, Philippe presented an update and showed, nonetheless, whilst these responses may not be profoundly deep initially, over time they improve. So this was well tolerated, convenient, and effective, and very importantly, both the PFS and OS was excellent, and critically, in terms of non-hematologic toxicities, there was no signal seen. So a well-tolerated all-oral regimen, and Philippe is building on this by now switching to a twice-weekly Ixazomib schedule to further improve induction remission. And basically, this, of course, we think may hold the benefit of a higher quality of response going forward. So wait to see in that space. Now, what about Ixazomib as part of maintenance? I do want to spend a little bit of time on this because it was presented at ASH, a very nice paper led by Dr. Patel from the MD Anderson, in which they looked at the impact of Ixazomib and lenalidomide maintenance, an all-oral approach. And what you can see here is high quality of responses improving with Ixazomib lenalidomide maintenance, and yet also at the same time relatively good and favorable tolerability profile. So a very exciting approach for the future, and certainly further randomized trials in this setting are planned. This also just gives you the best responses over time, as well as the PFS estimates seen overall. One area of interest in this particular study is in the higher risk group, and we're looking forward to data in that regard. Now, in terms of new maintenance strategies, I also want to touch on the emerging role of Elotuzumab in this setting. Elotuzumab, as many of you may know, targets CS1 and is a unique immunoadjuvant antibody that's very well tolerated. It activates natural killers, and in combination with lenalidomide, it's exquisitely active. So this particular approach in terms of a maintenance strategy has been explored, and again, data was presented at ASH suggesting it was both well tolerated and at the same time there was an improvement in the quality of response, and importantly, this was also in the high quality area, i.e. stringent CR. And what was particularly exciting as well was that this was in fact not only well tolerated, but the number of patients achieving CR may be an actual underestimate because, of course, we have the false positive of the circulating antibody limiting us in the ability to estimate overall CR rates. So when you look at this data, you can see that perhaps this might be a very exciting approach in the maintenance setting. Now, what about further work with antibodies? Well, some of this has been really exciting, and I want to share with you some lovely work presented from ASH at 2017, again, building on Andrei Jakubowiak's work, and this time presented by Dr. Achai Chari, who's part of that study team. And what Achai showed was the results of Daratumumab combined with KRd as an induction remission strategy in newly diagnosed myeloma. Now, this is a particularly promising platform in my view. And what you can see here from what Achai presented is not only do we have exceptionally high quality of responses after 4 cycles, but this builds over time. So if you look at best response overall, everybody achieves a response with a very high rate of VGPR and an equally very impressive high rate of CR and stringent CR. Now, this is a single-arm study, obviously, and the numbers are small, but this is nonetheless very encouraging, I think, in my view. And if you look at the efficacy outcomes, particularly in terms of longer-term follow-up, recognizing the median remains relatively short, we've got a very exciting PFS rate with an overall survival of 100%. And what's very important is stem cell collection was not adversely impacted upon with the integration of daratumumab. So this clearly provides us with an outstanding clue to the future with this approach. Now, in that same spirit, the so-called GRIFFIN study is being led by my colleague, Dr. Peter Voorhees, as part of the Alliance. And what we reported at ASH in December of last year is not only has this RVD-DARA approach equally proven very safe and feasible in this setting with excellent yields, small number of patients that Peter reported on in December. But critically, what you should know is that actually we're almost fully accrued now to this trial, looking at the randomized phase 2 portion, which is RVD-DARA versus RVD alone, followed by transplant. And this data so far, we think, is very promising in terms of safety, and we hope to see exciting efficacy data comparable to what I just showed you from Dr. Achai Chari going forward. And finally, there's a fabulous phase 3 trial ongoing right now, led by, again, Philippe Moreau, the Cassiopeia study, combining VTD, obviously a preferred regimen in Europe, with or without daratumumab in stem cell transplant eligible patients. And this, I think, will be very exciting in terms of outcome, and we're looking forward to information from it. One point to mention is that the maintenance is limited to 2 years and consists of daratumumab in one arm versus observation in the other. And this arguably may be a limitation to interpretation of this trial in the US setting. Now, in the last couple of minutes, I want to close by talking to you a little bit about MRD, because we think this is a very important tool that we can exploit in the transplant setting, and particularly in the research arena. Now, why is MRD important in myeloma? Well, the good news is we have treatments that are getting an increasing proportion of patients to that point, and we're evolving technologies that appear to be even more sensitive and specific as these fields emerge. And I especially want to acknowledge my colleague Nikhil Munshi, who published this in JAMA Oncology last year, showing basically the importance of MRD negativity in patients achieving CR, and if you look at overall survival in his analysis, a significant benefit being seen. So this seems to be a critical tool, certainly in the research arena, that we should take forward. Now, Nikhil and Hervé Avé-Loiseau, as part of our IFM DFCI effort, have taken this forward. And what's really important to recognize is that we've discovered that the next generation sequencing assay does appear to be more sensitive than the flow, certainly in this particular setting, recognizing that the technologies continue to evolve. But very, very important, patients with MRD levels below 10 to the minus 6, regardless of the technology, showed significantly better PFS than patients not achieving this level. So we think that MRD could be considered as a novel surrogate biomarker for trial evaluation, and sensitivity below 10 to the minus 6 appears to be the most important in terms of outcome. Now, what was really interesting from this and presented at the ASH meeting in December by Hervé is that RVD alone in our study achieved MRD with or without transplant, and the outcomes were exactly the same. So why this is so important is it gives us a real tool that may allow us to say to patients, if you achieve MRD negativity without transplant, that may be just as good an outcome as having one, and so that needs to be taken forward. So literally in the last couple of minutes, I want to conclude by saying, well, what is the way forward in myeloma for our current transplant-eligible patients? I'm very pleased to report to you that the Determination study, which is the US arm of the IFM-DFCI collaboration, has completed accrual, and we have randomized 722 patients. This has been with the phenomenal support of the CTN, and this study has the number CTN 1304. Its algorithm is summarized here, and as you can see, it's early versus late transplant. And as I've already alluded to, from our French partners, we saw that there's no difference in survival, actually, with median follow-up at 4 years, but there is a PFS difference. The critical difference in the US trial, though, is that lenalidomide maintenance continues until progression. And so far, we've not seen a meaningful difference at pre-planned analyses between the two arms, but more to follow, obviously, as the data mature. I especially also want to acknowledge a future direction being explored by my colleague Dr. David Avigan, again under the so-called CTN protocol 1401, where David's looking at induction remission, treatment, transplant, and then len maintenance, integrating what I think is a fabulous technology of DC myeloma vaccine fusions, a very exciting new area. This trial is moving along very nicely and accruing steadily as part of the CTN. So again, a clue to the future directions as to where we may take transplant. And then finally, we have proposals for Determination 2, the follow-on to the trial that I just alluded to. And whilst we're in the midst of deciding what induction remission makes sense, we are committed to integrating antibody therapy to this with CD38 targeting antibodies in the form of Daratumumab, first and foremost, and integrating immunomodulatory maintenance regardless of a treatment arm. But we propose to use MRD to guide our therapy in terms of going forward so that we can reasonably spare patients who don't need a transplant necessarily from those who do. And our hypothesis is that if early MRD negativity is achieved, can we defer? And why is this important? Well, not only may it have an importance from an efficacy point of view and acute toxicity, but there's a cautionary note. Long-term consequences of treatment in our myeloma patients now really matter because our patients are living 10 and 15 years. And therefore, this entity of potential secondary MDS AML is becoming something we need to fence off and be very aware of. So we're now going to move on to our next part of our conversation. It's my pleasure and privilege to introduce Faith to you, who's going to talk to you about what we do in relapsed myeloma. Thank you. Faith, beautiful.
Thank you. Okay, so as Paul mentioned, we're going to move on to what happens in the relapse setting. So this is really showing the results of the US stamina study. And we've already seen the slide, but what I want to show is exactly where we're getting to with upfront transplant. And you can see that the PFSs now are really very impressive. However, as Paul mentioned, sadly, patients do continue to relapse. And this is a very nice study that's come out of the Mayo Clinic from their database, really showing how patients relapse following transplantation. And I think it fits very much in with my own clinical practice, that the majority of patients actually have a biochemical relapse, whereas only 30% of patients go on and have some form of systematic relapse. And so that leads us to the question of how do we decide when to treat patients after they have relapsed? And certainly it used to be that we always said we shouldn't start treating patients until they have CRAB features of disease. But I think if we know our patient is relapsing, and particularly if they're relapsing rapidly, given how many effective therapies we now have, that we could argue that it's actually, we should get in there and treat just prior to the development of CRAB features, and watching a patient until they have another fracture or something like that is probably not ethical any longer. But we certainly do need to be very careful. We know that some patients may relapse very quickly, and we need to get in there and to proactively start treatment on those patients. There are a number of prognostic factors which certainly apply at relapse as much as they apply at presentation. And we're particularly looking out for those patients that are continuing to have clonal evolution of their disease, but also that have a poor performance status, because that's clearly going to affect our delivery of chemotherapy. And again, another data from that Mayo paper. And what they did was they looked at patients who'd had a transplant and then compared the outcome of those patients that had had more than 24 months with their first transplant as far as progression-free survival to those patients that had had less than 24 months. And you can see that those patients that had done well with their first transplant actually go on and do very well overall. And I guess the question is that just a characteristic of their disease, or is it their ability to either tolerate chemotherapy or moving forward, their general wellness? What I would say is these are patients that relapsed within 24 months of their transplant. And the database cutoff they actually had for this study was somewhere around 2010, I think, from memory. And so many of those patients would not have been exposed to the new drugs with new mechanisms of action. And so I think that we would be very hopeful that if this analysis was to be repeated and to include those patients, because the drugs work in a different way, you'd be hopeful that that curve would be shifting up. So obviously we're talking to a transplant community, and so what is the role of transplant in the relapse setting? And I think there's no doubt that there is still a role. The number of randomized studies in this setting are actually very, very small. This is a study from Gordon Cook and colleagues in the UK, which compared transplant to ongoing low-dose chemotherapy, and so has over the years come under a number of criticisms, but I think it probably is the only randomized study in that setting, which clearly shows those patients that go on and receive a second transplant really do benefit from that approach. So if we're not going to take that approach, then the question is, what should we take moving forward? And the NCCN have recently updated their guidelines, so this is very much hot off the press. And as usual, we've got a number of different categories of suggestions. But really one of their main take-home points is that we should be thinking about using a triplet regimen rather than a doublet. So really very much mirroring what Paul was saying in that newly diagnosed setting. So let's start with some of the doublets. So clearly the initial study, which is now kind of 5 years old, and as we all know, such a lot has changed in myeloma in the last 5 years, showed that the pomalidomide with dexamethasone is better than high-dose dexamethasone, and the finer details of the study showed that POM was effective even in those patients that were refractory to proteasome inhibitors or refractory to Revlimid. And as we move forward, you'll see that actually now that has been built on, and many people are using either pomalidomide with an antibody or indeed pomalidomide with one of the proteasome inhibitors, really working along those lines that a triplet is better than a doublet. What other doublets are out there? Then there's really nice data comparing carfilzomib and dexamethasone to Velcade and dexamethasone. In this study, the carfilzomib was used at the higher dose of the 56 milligrams per meter squared, but you can quite clearly see that there is a dramatic improvement in the progression-free survival supporting the use of CARF. And certainly at ASH, the overall survival data was presented from this study, and again, it showed there was an overall survival difference for those patients that received carfilzomib. Working on the theory and the theme, however, that this triplet is important, there's also very nice data combining carfilzomib with lenalidomide and dexamethasone, and really showing that that triplet is more effective than the doublet. But again, data presented at this year's ASH showed that that translated into an improvement in overall survival of up to a year. So really quite impressive results. There are certainly other studies out there. I did want to mention that the neuropathy rate in this study was particularly low, and really meaning that patients can stay on the drug for a long time. The other proteasome inhibitor, again, has shown to be very effective. So Ixazomib, the oral inhibitor that Paul spoke about earlier, and again, similar results showing the efficacy of the 3-drug compared to the 2-drug when we're combining with Revlimid and dexamethasone, and again, showing that tolerability that patients can maintain their therapy for the 2-year period. Certainly, the excitement in myeloma is around antibody therapy, and this has dramatically changed our approach in this relapse setting. And so I just want to briefly talk about the 2 antibodies that are most widely used. So we've got Daratumumab and Elotuzumab. So as far as Dara is concerned, again, really excellent studies combining Dara with Revlimid and dexamethasone, triplet drug regime showing a very excellent 1-year progression-free survival. Again, updated at ASH, and you can see that the RD arm had, I think, what we kind of expect from RD now, about that 18-month mark. But at the time of analysis, again, the median hadn't been reached for the Dara. But, I mean, there's certainly a hint here that we're expecting the difference to be really quite impressive. One of the nice things that we've discovered is that these antibodies can be combined with many of our standard agents. And so the other study which has shown this is with Ixazomib, and clearly again shows the 3-drug combination is better than the 2. And as Paul's already mentioned, there's also data out there now as well combining with the other proteasome inhibitors. I think following on from the theme earlier about MRD being important, it was very unusual to see MRD negativity in the relapse setting, but certainly these drug combinations do show MRD negativity. And although you can see here that the patients that are MRD negative from either study have a much prolonged progression-free survival, I think the important thing to note is that you're more likely to be MRD negative on the triplet and therefore be able to benefit from that prolonged PFS. And as I said, the studies are now moving forward to include some of the other agents, and this is very nice work published by AJ, showing that you can combine Dara with Pomalidomide. And I think you'll notice here that we're talking about really excellent responses. The overall response for this setting was 60%, but you can see that many, many patients were achieving very good responses with very minimal or at least manageable side effects. There's also lots of data now which has been updated looking at Eloquent and Elotuzumab. So this is a study combining that with Revlimid and dexamethasone compared to Revdex alone. And this is the updated progression-free survival. And I think what's really interesting is that it's maintained. It's really definitely there. But when you look at the overall survival curves, I just think this is fascinating that that LO arm seems to be separating out as we go on with time. The biology as to why that would happen has resulted in lots of debates, but certainly we have another excellent antibody in our toolbox. But the studies don't just stop there. There's lots of progress going forward, and I think one of the next wave that's going to be coming along is the Isatuximab. So that again targets CD38, so we're going after the same target as Daratumumab. But one of the interesting things that has been found is that not all antibodies are the same, and it really depends a little bit on how much you're going to be targeting your complement, your ADCC, your ADCP, and that means that you get different overall response rates and potentially translating into progression-free survival. And so the early studies of this have been very impressive, and Joe presented some of the phase 1 data at ASCO, really showing that we can combine the drug very nicely with pomalidomide. And when the data at ASCO, which Paul updated at ASH, really shows that, again, we're getting extremely good response rates in these heavily pretreated patients. If we remember, these patients will have seen a proteasome inhibitor and an IMiD, and indeed many of these patients were actually refractory to both drugs. So quite exciting times, I think, on the antibody front. I think one of the interesting things going along with this slightly different mechanism of action is, yes, you do see some infusion reactions, as you do with daratumumab, and again, it seems to be mainly on the first dose. I think, interestingly, the infusion time for ISA is slightly shorter than for Dara. And this has led to a number of different clinical studies which we're eagerly awaiting to report out. And certainly there's a randomized phase 3 really aiming to get the drug its FDA approval. But also we have studies looking at the combination with carfilzomib and then also looking at the combination upfront in patients with US standard RVD. So what's the next wave, okay? What's going to be happening next? So I think there's 3 targeted agents I'd like to just briefly discuss. The first one is selinexor. So let's all go crying and screaming back to our biology med school. And essentially, we know that we need a lot of trafficking of molecules from the cytoplasm to the nucleus. And this involves a number of importers and exporters. And what EXPO1 does is it actually helps to export things from the nucleus back into the cytoplasm. And it's particularly important in exporting tumor suppressor proteins. And so the idea is that if you inhibit this, then you can induce cell death. And clearly, many of its targets are important in myeloma cell biology. And just hot off the press, this is published in last week's JCO, the results of the phase 2 of this study, which is called STORM, where selinexor is given with low-dose dex. And what I really want to point out is that these patients are really heavily pretreated, and they are essentially refractory to everything. And so although you sit there and think, oh, only 20% faith, actually in that patient population, that is a really very impressive response rate. And again, you can see that not only are we seeing those responses in refractory patients, but also in the patients we worry about with those high-risk cytogenetics. Its side effect profile is actually much more like what I call a traditional chemotherapy drug. And so I think we're all very much used to managing those kind of side effects, so antiemetics and low blood counts. And again, the drug has been tried and is being combined with a number of our standard agents. I particularly wanted to point this one out as it's combined with bortezomib. And I think that these results are particularly impressive along the lines of showing that there is definitely some synergy going on here, because for these PI refractory patients, we have a response rate of 43%. And then, as one would hope, it's also being combined with antibodies. And again, you can see it's very easy to combine with the antibodies, and again, is resulting in pretty good responses. Although this is just a small study, clearly we need to wait for more results. Okay, so what else is happening? I think that we're all very excited about CAR T cells. I've just chosen to show data on the Bluebird compound, but there are actually a number of other very exciting compounds in myeloma. The ones that are the furthest along in clinical practice are those that are targeting BCMA. And certainly they seem to have extremely impressive responses. And so when you look at this slide, if you're yellow or purple, that's a good thing, okay? So you can see that of the patients that were treated, and there was a median of 7 lines of therapy for these patients, so they were truly heavily pretreated, the overall response rate is 94%. So very, very impressive. Clearly, we've already heard a lot at this meeting about needing to manage those side effects, and I think that's important as we move forward. And finally, the last drug I just want to mention on this kind of targeted theme is venetoclax. Now, we all know venetoclax as being a drug for CLL, but it actually turns out to be pretty effective for myeloma. So venetoclax is a BCL2 inhibitor, and many myelomas are actually highly dependent on BCL2, particularly those with an 11-14 translocation. So that's somewhere around 20 to 25% of patients. And this is a lovely study published last year by Sajid Kumar, which shows that patients were able to induce a response with venetoclax. It's not just the 11-14 patients. Other patients do also have a response, but it's primarily those patients that seem to be effective. And this has led to a phase 2 study of venetoclax just in that patient population. But the other thing we know over the years is that actually bortezomib is able to alter the ratio of BCL2 to MCL1. And therefore, by combining venetoclax with bortezomib, there's the potential for synergy. And Phil Moreau, in the same edition of Blood last year, had some very nice data showing that synergy in a phase 2 clinical study. And that's led to this phase 3 design of looking at venetoclax with bortezomib against bortezomib dex. So I know that's been a kind of a bit of a whistle-stop tour even, but what I'd like to summarize is that we need to be careful how we select our therapy. Triplet, generally better than doublet. Ideally, we want to have something where the patient is not refractory to those agents. Certainly, those antibodies are now well established as part of our regimes. There's lots of new antibodies coming through, including those targeting targets we already know about, but also targeting other targets. And then we have a number of new agents coming through as well, which are going to add to our repertoire of drugs that we can use in the relapse setting.
So the good news here is we're also ahead of schedule, which is particularly refreshing. I must speak for myself. And so in that context, we've got plenty of time for questions. And we've got a few here. And I'm going to start, if I may, with Faith. And I thank you, all of those who put questions forward. First and foremost, and I think this is one of the most interesting, given the outstanding session this morning from Stefan Grupp. Where is the therapeutic position of CAR T cells in myeloma, Faith? And do you see it replacing autologous transplant?
Okay, so at the moment, the majority of patients who have received the CAR Ts have been, I think the median number of cycles in the studies is like 7, so it's very much a kind of end-stage treatment currently, as you would expect for any new therapy. The results have been really very impressive, and the challenge over the next few years is to see what the progression-free survival is going to be from those studies, and also the management of side effects. I would say that if both of those can be accomplished, I could imagine it moving into the relapse setting, where we could, maybe replace the role of a second autologous transplant. I think in the upfront setting, we're actually now finding that many patients, the median PFS is 5 years, 10 years. And so I think that the toxicity issue may be an issue there, unless you're maybe one of those patients with very high-risk disease, where we know their median PFS is maybe only 3 years or 2 to 3 years, in which case that risk may change.
That makes great sense. And then the related question from the same questioner, and thank you for the question here, because it's a very good one, is in addition to CAR T cells, targeting BCMA and some of the antibody drug conjugate data at ASH were very promising. Do you have any comments about that, Faith?
Yeah, no, I think that's, we obviously didn't have time to go through that, but I completely agree. There's a whole host of new antibodies out there. There's kind of naked antibodies, there's antibody drug conjugates, and then there's also the bispecific antibodies. And I think it's going to be interesting to watch that therapy move alongside the CAR T cell therapy and to see where we end up.
And the questioner touches on that by saying the challenge that this person faces with CAR T is that he can't get a patient into a program because there's none available or no slots available, which I think is a good point. CAR T is very much a numerator experience in terms of patients who are available to participate are enormous, and the number who actually get through are more limited, so a good point. And the final comment from the questioner is the other antibodies are off the shelf, and I think that's a very fair comment. That relates to another question that comes from another questioner, which is the concern that if we use daratumumab early in induction remission treatment, the questioner says, the results are so promising, it would seem that they may replace transplant. But the question is, if treatment fails, will re-challenging with Daratumumab be successful? And I guess my answer to that would be it's an excellent question which we really don't know the answer to. But my sense of it is, from my own practical experience with using Daratumumab in relapsed refractory myeloma, is that revisiting the antibody in combination with other drugs, and in particular looking at schedule, for example, weekly versus less frequently, we can recapture response. But it's a great question because there are a number of areas of research where we're looking at CD38 resistance to better understand how that occurs and what drugs may help us. For example, there is evidence that by the use of panabinostat or other HDAC inhibitors, you can upregulate CD38 expression. And so with that, you might be able to restore response. So a great question, and I think hopefully areas not just other antibodies, but other strategies which might allow us to overcome that problem. And I guess my question to you, Faith, would be what place do you see, for example, Ixazomib having? Because induction remission strategies have not been perhaps as compelling as they have been for Dara-based strategies. I liked what you talked about Ixazomib. Do you see Ixazomib as a good maintenance antibody, for example?
Yeah, I mean, in some ways I feel a bit sorry for Elo because it came along and then Dara came along as well. We suddenly went from no antibodies to 2 antibodies. So I think the data on LORD is really very compelling, but also the data you showed of Elo post-transplant in that maintenance setting is also very compelling.
Yeah, it's very well tolerated. Yeah, I agree. I think apart from, this risk of chest infection, which is real for all the antibodies, Elo in itself seems to be very well tolerated. The last question is to do with toxicities and acute versus chronic, and the real issue, the question that this raised, which I touched on, was this higher risk of MDS-AML that's been observed post-transplant. I do want to emphasize the rates are very small, so I think that's a key thing, but the follow-up in some of the databases remains short, and the question is asking, what clues do we have? Well, there's some very nice work being done in lymphoma to try and fence off those patients who may be more vulnerable to alkylator-mediated genotoxic damage. In myeloma, that work is being undertaken as part of these randomized trials, but I can share with you that in the French experience, there was a higher rate of death from AML-MDS in the transplant arm compared to the non-transplant arm, although that was very small for both arms. So certainly don't want people walking away with the impression that we're seeing tons of AML-MDS from transplant. We're not, but the risk appears to be real, albeit small, and hopefully we can fence people off in the future. And certainly for younger patients, keeping transplant in reserve if they're looking to fight their disease for 10 to 15 years does seem to make a great deal of sense, but hopefully more tools in the future. And I think that those are the key of the questions, and we're absolutely on time, Faith. So I think
Amazing.
At that point it is actually. So we just really want to close by saying an enormous thank you very much to everyone for coming and for those particularly who stayed for the question and answers. And obviously if there are any other questions we haven't touched on, Faith and I will be here for a few minutes to address those for you. So thank you very much indeed, and please enjoy the rest of the meeting. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/JDR. This activity is supported by educational grants from Adaptive Biotechnologies, Celgene Corporation, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Karyopharm Therapeutics Incorporated, Sanofi Genzyme, and Takeda Oncology. This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peerview Institute for Medical Education.